All righty. I had to try to rein in my comments, and I hope I didn't do too short of a presentation on some of the studies I'm going to show you. But the last time I talked about biomarkers and AKI to this group was in March of 2008. And it's astonishing how much more data there is now. And I really feel like this is right around the corner for us. So without further ado, here's what I'm going to do today. I'm going to review very briefly the current criteria for diagnosing AKI. We're going to review the biomarkers that we currently use and their limitations, which I'm sure most of you are very familiar with. We're going to talk about some of the new biomarkers. There is no way I could talk about all the biomarkers, so I picked my favorites, the ones that I think are going to be the most useful and the most likely to be available soon. We're going to review potential use of the new biomarkers in a couple of special circumstances that are relevant to some things that are coming up for us in the near future, and I thought I'd go ahead and talk about these. And then when we get Dr. Finkel here in November to talk about ultrafiltration, hopefully we can get some complementary information from him. So here we go. You all know about the rifle criteria. The key things I would point out about the rifle criteria are that it's based on creatinine and urine output. And creatinine is not the best marker on the planet for identifying acute kidney injury early, and so our criteria is flawed from the get-go. I also have to say that since I'm old, my first reaction to any new system is that why do we need it? But we needed criteria for a diagnosis of acute kidney injury so that we were all comparing apples to apples when it came to looking at the literature. So the rifle criteria and the AKIN criteria, although not the best working way to figure out acute kidney injury accurately and in a timely manner, at least it means that we're all talking about the same thing when we look at the literature. The AKIN criteria is stage 1, let's see. The top square is stage 1, the middle square is stage 2, the bottom square is stage 3. Again, you can see the criteria are creatinine and urine output. I don't think a nephrologist will ever stop thinking that urine output is important. It's a hugely important feature, but as you know, you can have decreased urine output with obstruction, with prerenal states. So it doesn't always represent acute kidney injury, acute parenchymal kidney injury. But these are the two systems that have been put out there over the last, I want to say, 7-ish, 8-ish years, so that the investigators are all talking about the same kinds of patients. So what's the problem with creatinine? Well, we again, old nephrologists, we're real comfortable with creatinine. We know what it means, we know how to interpret it, we follow it over time. It's a pretty good marker for CKD, following CKD patients. But in the acute setting, it just doesn't differentiate prerenal, intrinsic parenchymal renal disease and postrenal obstruction. And we can do some of those other things easily because one of the first things we do is give people a bunch of fluid to fix any prerenal features and do a bladder scan or stick in a Foley or do an ultrasound so that we can rule out obstruction. But nonetheless, it is certainly not a specific marker for what caused the kidney disease. And it certainly doesn't happen quickly so that we know immediately that someone's getting into trouble with acute kidney injury. As I said, it's really nice in the chronic setting, and we all use it very comfortably, but in the acute setting, it's got some limitations. It's also one of those factors that is affected by lots of things that have nothing to do with the kidney function. The older person with less muscle mass, the female patient with less muscle mass, the patient who has been on a diet and has lost muscle, or the patient who has been exercising like crazy and gained muscle. It means that creatinine, even in the same patient from year to year, may not mean or measure the same things because of these variables that are pliable. So it's not one of our best markers of acute kidney injury. And probably for those of us who are interested in acute kidney injury in the hospital, this is it's a marker that rises late in the game. If you were to think that, gee, the minute I see evidence of acute kidney injury, I'll jump in and do this and save the day. Well, if you're waiting for the creatinine to rise, you're 2 to 4 days behind the game because that's how long you'll wait to see that rise. So it's not very timely, and that's its biggest drawback in my opinion. In non-steady state conditions, the creatinine based on estimates of GFR, it's not accurate. So everybody who's rotated with me in the hospital and sees me pull my hair out when the house staff are ordering 24-hour urine creatinine clearances, they're not useful. The patients are not at steady state, and that's one of the problems with creatinine as well. And then finally, depending on where your baseline renal function is, a significant proportion of the creatinine that ends up in the urine could have gotten there by tubular secretion rather than GFR. And you never really know what that percentage is in any given patient because everyone produces creatinine and excretes it at different rates. So creatinine's the old tried and true one that we're pretty comfortable with and we know how to use it, but wouldn't it be nice if we had a better marker? And so if in the ideal world, these are the things that I would like an ideal biomarker to do. It would be nice if I knew the minute the tubule cells were stressed so that I could do all the protective things under my power to try to prevent overt injury. It would be nice in being able to differentiate tubular dysfunction, ATN, from prerenal state or from glomerulonephritis or from renal artery stenosis or from obstruction, and I really cannot do that with a creatinine. It would be lovely to have a biomarker that would not only tell me I've got acute kidney injury, but where it is. And so if I knew that it was proximal tubule versus distal tubule, or if it was an ischemic injury versus a toxic injury, I might be able to be smarter about what my next step in the management of that patient would be. It would be nice to have a biomarker that would tell me I'm in for a rough ride. This is going to be a horrible case of ATN. We're going to have dialysis requirements, and this is a patient that's at risk of dying. It would be nice if I had a marker that would tell me that. And you will see from some of the data I show you today that we're reaching that point slowly but surely. And then it would be really nice if I thought I was doing something good for the kidney, that I had a marker that would tell me that yes, I've done something good and the marker is modified in some way after the intervention. So we really can't even treat acute kidney injury and intervene appropriately because we have no way of measuring if we've been effective or not. So an ideal biomarker would be much faster and would be able to help us address some of these concerns. So this is by no means an exhaustive list of the novel biomarkers that have been looked at, but I will tell you the ones that I'm going to talk about reasonably extensively are the top 4. Cystatin C is something that's been around for a long time, and the longer I live, the more I think we really need to get this here. And Dr. Mazur and I have talked about this before and sort of drug our feet, weren't sure what we'd do with it. And my argument has always been, well, so I know the kidney's failing earlier, I can't do anything about it anyway. But I think that day may be coming where we might be able to do some things. So knowing about injury earlier might be appropriate. Cystatin C is one tool. Kidney injury molecule 1, also known as KIM1, is another molecule that's got great potential. NGAL is one of my personal favorites. We've just wrapped up our ICU study here looking at urinary and plasma NGAL in acute renal failure. I do not have access to those results at this point. When I do, I will share them with you. IL-18 is another marker that I knew less about, but the more I read, the more impressed I was. And these last 3, the sodium hydrogen exchanger protein that's on the proximal brush border, that of course will get sloughed when you lose your proximal tubule cells, proximal muscle cells, urinary N-acetyl glycosaminidase, I probably said that wrong. This is a tubular protein that's actually been known about for a long time, but there's lots of things that can cause it to slough off in the urine, and it's not as specific as you might hope, but it's still out there and may be used in panels of markers someday. And then metalloproteinase 9 is another one that has been looked at. And as I said, this is not even a complete list, but I'm mostly going to spend my time on the top 4. So let me talk about cystatin C a little bit. The people that have been most excited about cystatin C are the doctors who take care of little people. The pediatricians have really enjoyed this, and you can imagine if we have trouble interpreting creatinine from person to person who are all adults, imagine the growing child who is definitely not the same person this year as they were last year. Cysteine protease inhibitor protein is released from all nucleated cells at a constant rate, and this is why you don't have the variables of what's your muscle mass or what's your age or what's your body mass. This is produced by all cells at a constant rate. It doesn't have to be adjusted for age, gender, race, or muscle mass, as I said. It's freely filtered by the glomerulus, and here's the fun part. It is completely reabsorbed by the proximal tubule, not secreted at all. So this should never appear in urine. And where we're measuring it for renal function on a day-to-day basis would be plasma values. So it's a surrogate marker for GFR, but it really isn't a true marker of acute kidney injury when used in this way. It's a certainly convenient way to follow patients over time, but it's not a really good biomarker, if you will, of acute kidney injury. However, if you look at urinary cystatin C, it shouldn't be there. And if it is, then you know you've got some tubular injury, and that is closer to a true biomarker of acute tubular necrosis. And this is not going to go up in the urine if you have GN, because even if you have GN, whatever gets filtered to the proximal tubule, if the proximal tubule is intact, it'll be reabsorbed. So it's not only a good marker in the urine of ATN, it's fairly specific for tubular dysfunction. So that's what I want to say about cystatin C. I think we've all read about that through the years, and that might be something we could reasonably soon incorporate into our armamentarium of diagnostic testing, even here. But to get on to some of the things that are not as well clarified, we'll start with KIM1, kidney injury molecule 1. This is a transmembrane receptor of unknown function, except that more recent data suggests that it's some sort of epithelial adhesion molecule. It's upregulated to really high levels in the proximal tubule after both ischemic and nephrotoxic injury. Since it's a transmembrane protein, what happens is that the part that sticks out of the cell, the extracellular domain, gets shed into the urine when the cell's integrity gets disrupted. And you can measure that, and it goes up with injury to the proximal tubule. This will distinguish ischemic from prerenal azotemia. If you don't have ischemia of the proximal tube cells, then there's no reason for this moiety to get shed into the urine, and it might help you separate prerenal from actual tubule injury. I write here that it's not detected in contrast nephropathy. I think there's some controversial literature out there, though, depending on who looks at it and depending on when they look at it after a consult challenge. So don't hold me to the not detected in contrast nephropathy, but that seems to be the predominant thought process right now. And it modestly predicts need for dialysis. The higher the value in the urine, the more tubule cells have been injured, the more you might think that it was a really good injury the kidney sustained, and you might get pushed to need dialysis. Oh boy. And this is some of the busyness I told you about, and I'll do my best to try to make these succinct. I tried to summarize a lot of the recent data so that I could build a case that these really are pretty good markers. There was a study in 2002 that described urinary KIM1 levels in patients with acute kidney injury. 7 of these patients had ischemic ATN, and the mean KIM levels in the urine were much higher than in the 16 patients with other causes for acute kidney injury. And you can see that the difference was significant at 2.92 in the patients with ATN nanograms per ml versus 0.63 in patients without ATN. Furthermore, in that study, they looked at biopsy of kidney tissue and were able to show that antibodies, fluorescent antibodies directed toward the KIM1 were markedly positive in the proximal tubule. So not only urinary findings, but tissue findings as well. If we move on, there was a 2007 study of a couple hundred patients that were hospitalized, and it showed correlation between the urinary KIM1 levels and the Apache 2 scores, with the highest quartiles of those two categories being highly correlated with both dialysis requirement and mortality. And I think that makes good intuitive sense to those of us who take care of these kinds of patients all the time. The higher the Apache score, the less likely you are to do well. And if you've got a high KIM1 level, you're also going to have renal failure that's likely to require dialysis. You throw dialysis into an Apache score, and you've made somebody have a higher mortality rate. There was a 2010 study looking at urinary biomarkers in 63 renal transplant patients who were biopsied for worsening renal function. And these were folks who had had some renal functional decline over about 3 to 3.5 years. And the decline not only correlated with the KIM-1 levels, but also correlated with graft survival. And this may be a tool we can use in our transplant patients. Interestingly, what they saw in the transplant patients was that the KIM-1 was a much better marker of tubular dysfunction, insult, injury than some of the other markers we have, like NGAL or IL-18. So that makes me want to remind you all that we've got all these urinary biomarkers becoming available, but it's not, and I hope I'm not going to simplify too much, it's not going to be as easy as the cardiologists who order troponins and they're positive, so you had an injury. These are going to be panels, most likely, where we'll have several biomarkers, and some may be positive, some may be negative, and they'll point us to the site of injury and perhaps even the cause of the injury. So in a graft survival issue in a transplant patient, if we had a panel and the KIM-1 went up and the NGAL and the IL-18 did not, that's consistent with chronic allograft dysfunction. And somebody who's at higher risk for having progressive failure of their kidney. Moving on to the next study, there was a study just last year published in a pediatric cohort of 252 patients. Of these 252, 7.1% had some acute kidney injury. And what they did in these kids was they measured KIM-1 levels in the emergency department and had an area under the curve under their ROC curve to predict acute kidney injury. And this was a really good number. Tejas, can I stand up with this?
Yes.
Because, oops, I'm going to draw a quick picture. You guys know me. I can't give a talk without using a whiteboard. Do you guys know what ROC curves are? Receiver, observe. There you go. Thank you. So a ROC curve, basically, here's your true positives and your true negatives. And here's your identity line. The more your line is close to identity here, the more this is true positives, and it's a good test. This is the area under the ROC curve. If it went like this, this would be a less reliable test, okay? Just to remind you what those mean, because a lot of these studies talk about ROC curves, and it's good to know what they're trying to tell you is specificity and sensitivity. The higher the number, the closer to 1, the better the test. So this, in the pediatric group, in the 252 patients, they had area under the curve of 0.73. If you think about some of the other tests we have, I had to do a little homework so I made sure I could explain this correctly. Do you know what the number is for T4 measurements? 0.86. So you get that's a test we use every day and we trust. So I think anything above 0.75 is a reasonable test. The closer you get to 1, the better it is. So now I'm going to move on to neutrophil gelatinase-associated lipocalin, NGAL. Much easier to say, NGAL. This is a 21 kilodalton member of the lipocalin superfamily expressed by immune cells, hepatocytes, and RTEs. Now, what I found very interesting is why for the 25 years I've been a kidney doctor, we've had creatinine and no other markers even thought of, and now all of a sudden we've got like 20 being looked at. Well, here's the reason. Now that the gene project has been finished, they've actually been able to look at which genes are upregulated in the setting of acute kidney injury. And then they find possible molecules that might be markers. And that's how some of these molecules, anybody even thought to look at them. And so this was identified through the transcriptome-wide search for genes that are upregulated after renal ischemia. It was initially looked at in animals and demonstrated that early post-ischemic upregulation of transcription and translation occurred, particularly in the thick ascending limb and to a lesser extent in the distal collecting tubule. Why not the proximal tubule? Well, some people even say that when you look in the literature, but on balance, most of the literature says the thick ascending limb is the key place where this is expressed. In my simple mind, that kind of makes sense, because if you're going to have cell destruction in the proximal tubule and debris is going to wash down to the thick ascending limb, that might be the best place for your scavenger molecules to be located. This molecule can be measured by ELISA or an architect assay. An architect assay, as I understand it, is a special assay that is specifically suited to the molecule you're looking for. And I'll talk a little bit more about that in a minute. So we at least have an idea what NGAL does, and this was another serendipitous discovery. This is an iron chelating molecule, and if you think about it, ferrous iron is Fe2+, ferric iron is Fe3+, the one that's soluble is Fe2+, and the one that's not soluble is Fe3+. What happens with these, we're so used to thinking about transferrin, we forget that there's lots of other molecules that do some iron transport, and it turns out that NGAL and the whole lipocalin superfamily, this is part of their job. And this also turns out to be one of the most incredibly expressed genes very quickly with renal injuries. And what it does is it scavenges the iron so that it can be used appropriately or hidden from the bacteria. So in a way, NGAL's not only a marker of acute kidney injury, it's also a molecule that may scavenge the iron debris and prevent oxygen radical formation downstream. So it may be a protective molecule as well as a marker molecule. How nice. We're starting to get to a point of a biomarker that I really like. There are 3 forms of NGAL, and you can see I put in my own little notes at the bottom here. The left hand is the apo-NGAL. This is the monomeric 25 kilodalton molecule, and this is also known as free NGAL. And this is the one that's also hardest to measure because it's so small. The other 2 molecules get picked up reasonably easily. So when I said there was an architect assay to look for this, what they've done is they've sort of made a sandwich that closes the monomeric form in between 2 markers so that they can capture it and measure it more accurately. So do you have to measure it that accurately? The short answer is yes, because depending on the cause of your renal dysfunction, you may have a range of NGAL levels. So not only are we going to have to know that certain markers represent certain types of injury, we're also going to have to know that certain levels of these markers may indicate different kinds of injury. And I will go into that a little bit more in a bit. The middle one is the NGAL that's actually holding the iron. It's a bigger molecule, it's dimeric, and this one is primarily made by polys. This is the one that you'll see in the bloodstream. The apo form you're going to be looking at mostly in the urine, but it's also in the bloodstream. And the last one, the 135 kilodalton complex with MMP9, this seems to be more important in the cancer literature, and I'll be honest, I did not go crazy looking at that because there was already so much to do, but this seems to be one of the ways where cancer can actually metastasize and become invasive. And this is a marker that the hematology oncology guys will be much more interested in, whereas I'm going to be much more interested in the monomeric form. So let's talk about NGAL, and I'm going to go through quite a few studies here because I think this is one of the molecules that has been studied a lot in recent years and in many different settings. So let's start with kids receiving cardiopulmonary bypass. In 2005, they looked at 71 kids undergoing CPB, and 20 patients developed AKI by the creatinine criteria. When they looked at the serum and urine NGAL levels, they both rose significantly within a couple hours of the surgery. How nice, a nice early marker. And if you look at these numbers, you can see that this wasn't, gee, maybe it went up a little bit. Urine NGAL went up from 1.6 in kids without acute kidney injury to as high as 147 micrograms per liter in kids who did have kidney injury. The serum levels, you can see, also did the same, but were not as dramatic. Hold that in mind, because I think that from our point of view, looking at acute kidney injury, we're going to probably be much more interested in the urinary values. And when you get to adults, that difference becomes even more pronounced. The urine NGAL at 2 hours after cardiopulmonary bypass gets plotted on one of these rock curves. Look at this number, 0.998. This means if your urine NGAL goes up 2 hours post cardiopulmonary bypass, you got it. I know it now. That's amazing. This is incredibly sensitive and very specific. A follow-up study to this in this same institution in 2007 came up with very similar findings, but they also had the additional finding that that 2-hour post-op level of NGAL in the urine correlated with the duration and severity of the AKI, and when they looked at the 12-hour level, that correlated with mortality. Theoretically, 2 hours after the bypass surgery, your insult should be fading away. And remember, being on a bypass machine is an inflammatory process. So if you think that that may be the player here and now it's gone, but your number's still going up by hour 12, that increases your mortality risk. Now, NGAL in adult patients having cardiopulmonary bypass. I'm going to start with a study in 2006. This was 81 adults undergoing cardiac surgery. They found that the NGAL levels were 4-fold higher in the acute kidney injury patients at 1 hour post-op compared to those who did not have AKI. Again, 1 hour post-op. You already had a feel for which patients were going to get into trouble. In 2009, a similar study, this time looking at 100 patients, showed that NGAL was, again, a reliable predictor of acute kidney injury, and that the degree of increase correlated with the duration and severity of the acute kidney injury. In several studies also predicted the need for dialysis. Next study, 2009, this was 50 patients undergoing cardiopulmonary bypass. And here's your ROC curves for predicting AKI in this population. It's not quite as pretty as it is for the children, but 0.8 for plasma NGAL, 0.96 for urinary NGAL. So again, I think from a kidney perspective, I'm very impressed by the urinary levels, and rather than measure both, I probably would just look at the urine levels. Now, here's some curves looking at the increase in NGAL post-cardiopulmonary bypass, and you can see the red line is the patients who had acute kidney injury, the green line is the patients who did not have acute kidney injury, and the top curve is the NGAL. And you can see very quickly it pops up, indisputably up. I mean, it's no gray zone at all. And those are the people who ended up having AKI. The higher that number goes, the more likely you are to be at risk for a higher or a longer course of AKI, as well as the need for dialysis. If you look at the bottom curve, that's our good old buddy creatinine. And look how long it takes for that to pop up and clearly show us that we've got acute kidney injury. So as much as I love creatinine, it may be time to find us a new marker. So what about the critical care unit? Again, this is kids. The pediatricians have been way ahead of us on this, by the way, and I think they've been disappointed in creatinine for so long that they jumped right on this bandwagon. In 2007, they looked at urine NGAL levels measured in 140 mechanically ventilated kids in the ICU, and the levels rose significantly 2 days before you saw the rise in creatinine. The degree of the early rise in the NGAL correlated with the severity and duration of AKI. In 2008, a subsequent study, again 143 critically ill kids, showed significantly higher NGAL levels in those with septic shock as opposed to those with SIRS, although both of them had completely higher levels than those with the normal controls. So shock had the worst values, SIRS had elevated values, normals were normal. So again, it can help you even separate out, gee, has this kid got sepsis or SIRS? And this level might actually point you toward this is a worse problem than you thought, treat aggressively for sepsis. Now we move to the critical care unit in the adult world, and these studies are a little more recent and a little smaller in general. The first one that I've reported to you is done in 2010. This is 88 ICU patients that are evaluated for urinary NGAL, and they found that the level was greater than 155 nanomoles per liter. Notice the different units. And that predicted acute kidney injury with an 82% sensitivity and a 97% specificity, sorry. The 2010 study looking at 45 patients with septic shock found that the urine NGAL level at 12 hours was a very good predictor of acute kidney injury, and the area under the rock curve here was 0.86. The plasma NGAL did not perform as well in this particular study, and that was a theme I saw throughout the literature, that in adults the urine NGAL really seemed to be a better predictor, more specific and sensitive than the serum NGAL. But that wasn't across the board, so again, keep an open mind. In 2010, a different study looking at 300 patients admitted to an ICU, they did find that the plasma NGAL was a good predictor of AKI development within the 48 hours following the elevated level. The rock curve here, the area under the rock curve here was 0.78, which is not bad, but notice how much less impressive it is than in the kids. There was a good correlation between the peak NGAL levels, the height of the NGAL peak, and the severity of the AKI. So we've talked about cardiopulmonary bypass, we've talked about kids, we've talked adults, we've talked sepsis, we've talked ICU, sick patients, but there's other places where NGAL can be used. And this was a study looking at heart failure. 2011, 119 patients admitted with acute heart failure decompensation. The NGAL levels on admission were higher in about 12% of the patients who developed cardiorenal syndrome type 1 within a couple of days of the hospitalization. The area under the rock curve for the diagnosis of acute kidney injury was really pretty good at 0.93, and the cutoff, notice here, the cutoff is lower than you would see with big inflammatory processes like sepsis or SIRS. We're talking about a level here of 170 nanograms per liter rather. The height and the duration of the NGAL elevation predicted subsequent development of the cardiorenal syndrome with 100% sensitivity and 86.7% specificity. Since we're looking at the possibility of having an ultrafiltration program here very soon for our cardiorenal syndrome patients, there's some very useful tools we can dig out of this that hopefully will be available soon, because I think they will really help us. And I will talk more about that in a minute. There was a 2008 study with about 640 patients admitted who had a single urine NGAL measurement made upon approaching the emergency room. These levels not only correlated with development of the acute kidney injury, but also predicted a compositive endpoint of all those things that pay my paycheck: nephrology, consult, dialysis, ICU admission, or mortality, with an incredible odds ratio of 24.71. So I have tried to present you a very balanced view of the literature out there related to KIM and NGAL, but I must say I'm very impressed that we really are going to have some tools very soon that are going to help make our lives easier. Here's the diagnostic cutoff for sepsis. It's right around 200 to 250. Above that point, you say you have an elevated NGAL, and you could say this person has a risk of acute kidney injury. But the level where you make your cutoff is going to vary a lot depending on the patient. For example, those cardiorenal failure patients tend to run lower NGAL levels, but if you follow trends over time, you can predict who is going to get into trouble with acute kidney injury because you've over-diuresed them. Their BNP will be coming down as you diurese them, their creatinine staying stable, but then the NGAL pops up. The NGAL pops up, it tells you, uh-oh, time to back off on the diuretics or we're going to have real live acute kidney injury. And that's a piece of the puzzle we do not have now. We don't know we're in trouble until the creatinine's rising and the patient's getting in more trouble. So I think in our cardiorenal patients, this may be an invaluable tool to manage them a little smarter. Okay, on to the next molecule. This is IL-18. IL-18 is, of course, in the family of inflammatory cytokines. It's an 18 kilodalton pro-inflammatory cytokine that's cleaved by caspase 1 and is preferentially found in the injured proximal tubules. The animal studies that have been done suggest that it's a mediator of ischemic injury, not only in the kidneys, but also in the heart and brain. And it's way beyond the scope of this talk, but there's a lot of literature out there about crosstalk between different organ systems that are suffering miserably and their effects on other organ systems. So if you get an IL-18 bump, you can imagine that the kidneys are not the only thing that are being involved. The urinary IL-18 is increased in ATN versus pre-renal stage, urinary tract infection, chronic kidney disease, nephrotic syndrome, but it's been shown to be higher in renal transplant patients with delayed graft function as well. So this is, so if we had one of our patients, and we see this all the time since we're doing CADs and extended criteria donors, patients' kidneys being a little slow to wake up, if you measured a high IL-18 level, that might be somebody that you're thinking is going to have a prolonged course before the kidney's really waking up, and somebody who may do less well in the long haul with their function of their kidney. And this is a marker that, because it's pro-inflammatory, may be not seen in all sorts of other kinds of acute kidney injury, and may be part of a panel that would help you figure out what the etiology of the AKI is. This is very busy, I apologize, but I'm mostly going to read this to you. This is a 2005 case control study. It was within the ARDS network trial where they actually banked urine specimens on the patients they were including in study, and they analyzed them subsequently for IL-18. These levels were significantly elevated 48 hours before you saw the rise in the creatinine, and were sure at that point that you had acute kidney injury. The mean level in the AKI patients was 104 picograms per ml compared to 0 in the non-AKI group. I don't know how much more black and white you can get, and if that's reproducible, that would be fabulous. The elevated IL-18 levels were also found to be an independent predictor of death. And that makes sense to me. If your pro-inflammatory cytokines are turned on nonstop, that's not a good thing. Another study in 2008 showed urinary IL-18 levels to be predictive in 103 critically ill kids with renal impairment compared to 34 controls that had normal renal function. The renal failure patients had a more than threefold increase in their urinary IL-18 levels, and these rose within a day or two before you actually saw the creatinine levels go up. When they did go up and stay up, they were also independently associated with mortality. So this is another marker that has great promise, and it seems to be can apply to multiple groups, both adults and kids, in lots of different settings. Have you guys heard of the TRIBE AKI study? Translational Research in Biomarker something or another, AKI study. They did a couple of portions to this study. The first one I'm going to talk about is the pediatric arm, which measured pre and post cardiac surgery urine IL-18 and NGAL levels, as well as plasma NGAL levels in 311 kids undergoing surgery for congenital heart disease. 17% of these children developed severe AKI that required dialysis or was documented by doubling of their serum creatinine. The kids that were in the highest levels of urinary IL-18 and urine NGAL had strongly associated with their AKI risk, and the odds ratios that you can see are pretty positive. The elevated urinary biomarkers also were associated with things that you'd predict. Sicker person, longer ICU stay, longer stay in the hospital, longer duration of mechanical ventilation, and the area under the curves for IL-18's ROC curve was 0.72, urinary NGAL was 0.71. Not fabulous, but not bad to help you predict which kids were going to need dialysis. In the adult group studied by the TRIBE AKI group, there were over 1,000 patients that were undergoing cardiac surgery that had these markers measured as well, pre-op and daily up to post-op day 5. They had a multivariate analysis that showed that the highest levels of both of these markers at 6 hours strongly correlated with the risk for acute kidney injury. And again, look at the adjusted odds ratios that are very positive. The higher the biomarker levels, The longer the length of stay, the longer the ICU stay, the longer the ventilation, the higher risk of dialysis, the higher risk of death. So I think that these are great markers, not only for what's going to happen with the kidneys, but what kind of risk your patient's at overall. Urinary N-acetyl beta-D-glucosaminidase, I think I said that right very slowly, is a marker that is a tubular protein. It can be attached to metalloproteinase 9 or in addition to metalloproteinase 9, and these are markers for proximal tubule injury. These can help you differentiate whether this is acute versus chronic. And that's something we face at least 5 times a day in the hospital. We have no track record, and we don't know if the creatinine we're seeing is a new thing or an old thing. And this may be a way that you can help tell that it's an acute injury rather than chronic kidney disease. And that's about all I'm going to say about that. The hydrogen sodium transporter in the proximal tubule obviously is preferentially located in the brushboard or the proximal tubule. So this is going to be seen in the urine when you have an acute proximal tubular injury. The assay is really tough though. I tried to read through it, and I even have a chemistry background, and I stopped. I just stopped. This is not a complete table. I stole this table, but you can see that each of these markers has some risk, has some benefits and some limitations, where putting them together in a panel might be really helpful to know acute kidney injury, why you got the acute kidney injury, how bad it's going to be, and this table is, as I said, incomplete, but it gives you the feel for why a panel of markers might be smarter than picking any one specific marker to use exclusively. Again, I go back to being old. I used to be able to take care of kidney patients before we had stages of chronic kidney disease. I don't know how I managed to do that. But you know, as everything in life, by the time it's sunk in and I've used it for a while, I realized that there really are reasons why it's helpful. And I think the CKD categories are useful for our primary care colleagues to know when to get us involved and when to get worried about a patient. It also gives patients a visual of where they are in their progression of chronic kidney disease. And the cardiorenal syndromes, I think, dear Lord, I've seen this 100 times too. But again, when you're talking about investigating and doing research, wouldn't it be nice if we were all talking about the same thing? So this just defines the cardiorenal syndromes. And when I think of what we see most, it's cardiorenal syndrome 1. Why do I see it most? Because I spend half my time in the hospital, and these are acute decompensated heart failure patients. So it's an acute heart issue that promotes renal underperfusion and acute kidney injury. Type 2 patients are mostly going to be outpatients who sort of live in semi-stable, I guess, rates of decompensation. And that chronic state of I need diuretics all the time and afterload reducers all the time, so I'm chronically going to underperfuse my kidneys. That makes sense to me too. Type 3 is a type that you're honestly going to see more often in children from all my reading, and this is where you get acute kidney injury and, for example, an acute GN in a kid with wild hypertension and volume overload with a little heart, that could really lead to a cardiac failure. So that's something you're most likely to see in younger patients. Type 4 and type 5, some people don't call these cardiorenal syndromes, they call them renal cardio syndromes because the kidney's the problem. Type 4 cardiorenal syndromes, progressive chronic kidney disease that leads to, and we all know this, we take care of these patients every day, accelerated progressive vascular disease. And then type 5 is systemic disease leading to simultaneous failure of the heart and the kidney, and I think the best example of this is sepsis. So with that in mind, what about type 1 cardiorenal syndrome and NGAL? We use diuretics like water in decompensated heart failure, and if we think we use them like water, you ought to see what the cardiologists use them like. By the time the creatinine's rising, you are already in trouble, and this is where NGAL might be a nice tool to know when to back off on the diuretics or you're going to cause more harm than good. So what has been proposed, and I've heard several talks on this over the last year, is using NGAL along with BNP, urine output, and creatinine to help you use your diuretics more intelligently. So if you're using your diuretics, you're getting a good urine output, the BNP is going down, the creatinine's stable, but the NGAL bumps up, that may be your warning to either back off on the diuretics or throw in the towel and say, you know what, this is a guy who's actually going to need ultrafiltration. And this may be one of the ways we'll be able to divide who can be diuretic managed and who may need more aggressive ultrafiltration management. Levels of NGAL signaled impending AKI, but these levels tend to be a lot lower than you would see in sepsis. So again, where is the cutoff may be different for cardiorenal syndrome patients than septic patients. The level that might get you nervous in a cardiorenal patient might be double digits, where in sepsis it's going to be triple or quadruple digits. So down here I've given you some ideas of where the averages are. Average NGAL level for an ICU patient is about 220 and sometimes much higher. Average NGAL level for contrast-induced tubular injury, somewhere around 100. And the mean for heart failure patients, 79. This is data that I got from Dina Cruz. If any of you have heard of her, she works with Ronco in Italy, and this has not yet been published. When I get it from her, I will pass it on. The UNLOAD study is an older study, but this was a study that looked at ultrafiltration versus IV diuretics in patients who were hospitalized for acute decompensated heart failure. It was a randomized controlled trial. It was unblinded. There were about 200 patients. The patients with high creatinines greater than 3 were excluded. So really, they were looking at a good population, people that you know have chronic kidney disease, but it's not horrible. Creatinines of 1.5 to 3. What they did was they ultrafiltered these folks with a blood flow rate of 10 to 40 cc's per minute, and it was heparinized. This was not with one of our CRRT machines. This was with an Aquedex machine that is just made for ultrafiltration. The fluid removal rate was about 241 cc's per hour, plus or minus 12.3 in the ultrafiltration group. You didn't do quite as well in the diuretic group, and look at the doses that were required. There was quite a range actually, so I don't want to say a lot, but there were some patients who required a lot. And when you looked at the two groups, this study turned out to be quote unquote negative. They were both similarly improved at 48 hours. They felt a lot better, whether it was ultrafiltration or diuretics. But interestingly, the ultrafiltration group was able to get a little more weight off. Why? When you ultrafilter somebody, you also remove salt, not preferentially water. So you remove it at the same concentration that is in your serum. So you remove more, so they lose more weight. And this was the one piece of this study that was clearly positive. They had better weight loss in the UF group than in the diuretic group. The 90-day readmit group percentage didn't shake out to be significant, but boy, it sure looks like a trend towards significance in my mind. Length of stay was about the same in both groups. So as much as I hate the extra cost and trouble of ultrafiltration, on balance, it didn't prolong their hospital stay too much. They had more weight loss, and they may have been able to stay out of the hospital longer. So this is something that we're really going to have to hear more about and think about as we approach our own ultrafiltration program. So the comments about this study, the mortality rates were really not different. The cost was, of course, higher with ultrafiltration. There was a more standardized approach with diuretics because we do this. We're good at this. We have a good use of Lasix along with the thiazides to give synergy, and the vasoactive drugs and the inotropic drugs. There was really not a length of stay difference. The comment after this study was, this is interesting, let's look at a bigger group. And this might be a good trick for people who are frequent flyers, bounce backs, or when we get our NGAL more commonly available, the people that whose NGAL pops up before we get them back into better compensation. Oh my, it is 1:29. And I told you the references are extensive, and I can print these out for you if anyone is interested. And I have a whole stack of more other references that I didn't even get to.